A 65-year-old man comes to the physician for fatigue lasting several months. He also has had several episodes of abdominal pain and constipation. Laboratory tests reveal sodium 143, potassium 4.3, bicarbonate 24, calcium 11.3, BUN 22, creatinine 1.5, hemoglobin 12.0, hematocrit 36%, MCV 85, leukocyte count 7,500, platelets 235,000. A peripheral blood smear is shown. Which of the following is the most likely diagnosis? And of course we have an image of a blood smear here. Apologies to any of you who are only listening. I don't want to describe it too much because it might spoil the question for some of you. So let's move on to answer choices. Choice A, diverticulitis. Choice B, immune hemolytic anemia. Choice C, microangiopathic hemolytic anemia. Choice D, sickle cell anemia. Choice E, myelophasic anemia. Choice F, beta thalassemia. Choice G, multiple myeloma. Choice H, acute tubular necrosis. Choice I, lead poisoning. Or choice J, systemic lupus erythematosus. I'll wait 5 seconds and answer the question. So I did give you a ton of answer choices here, but sometimes you do get questions like this and they'll give you a ton of answer choices, and you need to recognize that a lot of these answer choices are just obviously wrong. It's a true test of just how broadly you studied a lot of your diagnoses. But let's focus in on what's actually in the question, okay? So we have this patient who has fatigue, pretty non-specific by itself, abdominal pain, constipation. I mean, really not seeing anything super interesting yet. He is 65 years old, and that's going to be very relevant. And of course, I spat at you a bunch of laboratory studies here, and that's really what this question is all about. So you look through these. Hopefully you don't reference the normal range sheet too much while looking at this. I've said before, and other people will tell you this, it saves you time on the exam to just memorize a lot of these normal ranges. So going through these, a lot of these are normal. Sodium is normal, potassium is normal, bicarb is normal. Calcium is elevated. We have a hypercalcemia. BUN creatinine is elevated. So we have some kind of renal dysfunction, potentially. And we have a low hemoglobin alongside a low hematocrit and a normal MCV. So that means this is a normocytic anemia. We also have normal leukocytes and normal platelets. So this is an isolated normocytic anemia. Now, this blood smear, some of you are going to look at it and you're going to say, like, I really don't see anything. I understand sometimes it can be hard to tell, but for this image in particular, if you really just look at it, what's the impression you get? Well, it kind of looks like the RBCs are stacked on top of each other, right? They're kind of stuck to each other, which is an accurate assessment. This is a rouleau formation. So you combine hypercalcemia with renal dysfunction, anemia, and rouleau formation. We're missing one of the most telling elements, but they don't always give you every single symptom, right? So the thing that fits best here, especially in an elderly patient, is choice G, multiple myeloma. Very high yield diagnosis. Sometimes they'll only give you like one symptom and you still need to figure out that it's multiple myeloma. You just need to see the fact that, oh, I have an elderly patient and I have, say, a lytic bone lesion. Legitimately, there are questions where that's all they give you and multiple myeloma is the only answer choice that makes sense. So let's just go back to basics here. What is multiple myeloma? Multiple myeloma is where I have neoplastic proliferation or an overgrowth of plasma cells in the bone marrow. And these are monoclonal plasma cells, right? Basically only have one type of plasma cell, essentially. And of course, plasma cells produce immunoglobulin. So you're going to have a bunch of IgG being created by all these monoclonal plasma cells. So this overgrowth of plasma cells can lead to the characteristic lytic bone lesions. And this will manifest in a lot of questions as back pain, some kind of bone pain, or just obviously hypercalcemia like you see in this patient, which is why this patient has abdominal pain and constipation, right? Because that's a symptom of hypercalcemia. So, like I said, you have a bunch of plasma cells growing in the bone marrow, and they basically kind of crowd out the red blood cells or the erythropoietic cells, and that's why you get an anemia in multiple myeloma. In addition, the plasma cells of multiple myeloma will produce lots and lots of a monoclonal antibody, usually IgG, and that will go around the body wreaking all sorts of havoc. It can deposit in all kinds of tissues, leading to amyloidosis. So it can deposit in your nerves, causing neuropathy. It can deposit in your heart, causing restrictive cardiomyopathy. It can deposit in your renal tissue, causing renal dysfunction. So that's why when we talk about multiple myeloma, we use the acronym CRAB, which is calcium for hypercalcemia, R for renal dysfunction, A for anemia, and B for bone pain. Now, characteristically, and I didn't give you any of these in the question, of course, but characteristically, you can get M protein spike on protein electrophoresis. You can get the Benz-Jones protein urea. You can see the blood smear like we have here, a rouleau formation, which is where it looks like the RBCs are sticking together. And the reason this happens is because all the monoclonal antibodies running around your bloodstream, essentially, they can coat your RBCs and neutralize the negative charge on the RBCs, which usually causes RBCs to repel each other. So without that, they kind of stick together and make these coin stack formations. And of course, the most definitive thing for multiple myeloma is bone marrow aspiration. You'll find more than 10% clonal plasma cells and what they call the clock face chromatin. That's usually definitive for diagnosis. I should also note that even though you are producing large amounts of immunoglobulin, multiple myeloma often leaves you susceptible to infection, because even though you're making a bunch of immunoglobulins, they're monoclonal and they don't really function the way they're supposed to. So you end up being immunocompromised even though you are producing tons and tons of immunoglobulin. This is unintuitive to some people, but remember that your immune system works by being able to adapt to what antigens are shaped like, essentially. And multiple myeloma essentially prevents you from being able to do that because you're producing a bunch of the same type of immunoglobulin. So putting aside the fact that this patient does exhibit a bunch of the multiple myeloma symptoms, we do want to look at the wrong answer choices, right? So let's take a look at that. Choice A, diverticulitis. This is a pretty common thing you can see in elderly patients. This is basically an infection of a diverticula. So if it was diverticulitis, you would have infection signs, right? Usually you would have a fever and leukocytosis. And since it's infectious and an infection of a diverticula, you would think it's probably more acute most of the time rather than having this long-lasting fatigue that lasts for several months. Also, while anemia is possible from diverticulitis, it's usually because of bleeding from the large intestine. So occult blood would be positive. And more importantly, it would be microcytic anemia, right? Because it would be an iron deficiency anemia. Now, of course, there's some rare instances where you get questions where iron deficiency anemia is normocytic. But regardless, none of the symptoms here really fit diverticulitis. Choice B, immune hemolytic anemia. This can refer to many, many different diseases that basically cause an immune destruction of red blood cells. All you need to know is that if this was happening, obviously your body would be trying to make more red blood cells, so you would have an increase in reticulocytes. And because your red blood cells are being lysed, and you would usually see an increase in LDH and indirect bilirubin, right? And you would probably see jaundice as well. Like I said, the anemia in multiple myeloma is largely from the monoclonal plasma cells crowding out your erythropoietic cells. So there's usually no hemolysis going on, so you wouldn't have hemolytic symptoms. Also, immune hemolytic anemia obviously wouldn't explain hypercalcemia, renal dysfunction, rouleau formation. Choice C, microangiopathic hemolytic anemia. Talked about this many times in the past, very high yield. MAHA includes TTP, thrombotic thrombocytopenic purpura, HUS, hemolytic uremic syndrome, and DIC, disseminated intravascular coagulation. In every single one of these, you would have low platelets because your platelets are being consumed to create platelet plugs, and then when your red blood cells pass by, they'll get sheared or torn up by the platelet plug, essentially, and you're going to see schistocytes on blood smear as a result. Obviously, you don't see schistocytes here. And again, you would likely also see various signs of hemolysis. Choice D, sickle cell anemia. You can kind of eliminate this on age alone, because what are the odds of you diagnosing sickle cell anemia in a 65-year-old man? But even ignoring that, like I said, this is also a hemolytic anemia. So you would have hemolysis symptoms, and you would just have other symptoms that don't fit this patient at all. You would have stuff like pain in the extremities, and obviously you can also have hemoglobin S being detected. Choice E, myelophasic anemia. This is not something I made up, this is a real thing. It's just something that describes bone marrow being displaced by fibrosis, tumors, granulomas, which causes a reduced production of mature blood cells. You do not need to know myelophasic anemia. This is just some weird thing that I've seen as an actual distractor on a question. As is often the case, don't see things that you don't understand and then panic. They love doing that to you on USMLE. Choice F, beta thalassemia. Thalassemia, of course, is something you should know. Similar to sickle cell anemia, very unlikely you would diagnose beta thalassemia in an elderly patient. They would have symptoms throughout their life, most likely. And even though beta thalassemia minor is asymptomatic a lot of the time, they probably still would have been detected earlier on. Beta thalassemia minor can also present with a microcytic anemia. Beta thalassemia major, which is both genes being mutated because this is autosomal recessive, you have a complete absence of beta chains for hemoglobin, right? And as a result, on electrophoresis, you're going to have no HbA for beta thalassemia major, or reduced HbA in someone with beta thalassemia minor. And for both, you would have increased hemoglobin A2, increased hemoglobin F, obviously more severe in beta thalassemia major, which will have various other pretty severe symptoms, right? You'll have anemia, hepatosplenomegaly, failure to thrive. And because your body is trying to construct more red blood cells a lot of the time and construct more hemoglobin, certain parts of your bone will grow to compensate, which is what causes stuff like the chipmunk facies. And of course, a buzzy finding you like to hear about in a lot of resources is the target cells on blood smear. Don't rely on that. You'll only see that in like half of beta thalassemia questions or something like that. Obviously, if you see target cells, it's kind of a gimme, but they also like giving you thalassemia without the target cells. So one way they like giving it to you in some questions is that they'll give you something that looks like iron deficiency anemia with the microcytic anemia, but then the ferritin or the iron will be normal, which means that there's no problem with the iron, of course, and you might start suspecting beta thalassemia or just any kind of thalassemia. A lot we could talk about, but let's move on. Choice H, acute tubular necrosis. Of course, this patient does have renal dysfunction, but nothing this patient did should make you imagine an AKI. I mean, he's not really taking any medications that we know of. He doesn't have a history of like blood loss or MI or hypotension, which might have damaged his kidneys acutely. And AKI probably wouldn't cause anemia or hypercalcemia. A chronic kidney disease can cause an anemia over time because you have reduced erythropoietin, but AKI probably not. Choice I, lead poisoning. Lead poisoning can of course disrupt heme synthesis pathway, specifically ALA dehydrase, which converts delta aminolevulinic acid into porphobilinogen, as well as ferrochelatase, which is the final step, which converts protoporphyrin 9 into heme. I don't want to obsess too much over the heme synthesis pathway right now. Just know that lead poisoning can disrupt heme synthesis pathway at the beginning and at the end, essentially. And that leads to a microcytic anemia. And you can see basophilic stippling and sideroblastic anemia because since the heme synthesis pathway is being disrupted, you can't use up iron, which causes the sideroblast formation in the RBCs. Again, lead poisoning doesn't really explain a lot of this patient's symptoms. You could probably get abdominal pain, constipation from lead poisoning, but hypercalcemia, not so much. Choice J, SLE. So, again, this is one of those things where you're kind of raising an eyebrow because of the age. I mean, it's not impossible to see SLE in any kind of patient. SLE is very hard to diagnose sometimes. And it can lead to various immune-mediated cytopenias, including anemia, thrombocytopenia, leukopenia. But this patient just doesn't really exhibit a lot of the classic SLE symptoms, right? No rash, no arthralgia, and hypercalcemia and rouleau formation are not typical of SLE. So bring it back. I know this seemed like kind of a hard question for some of you who might be early on in your prep, but I think for a lot of you who are deep into your prep, probably didn't find this question too hard because multiple myeloma is a very high yield diagnosis that you need to know. And again, of course, remember CRAB, hypercalcemia, R for renal dysfunction, A for anemia, B for bone pain. And obviously know a lot of that other stuff, Benz-Jones proteinuria, M protein spike, rouleau formation, lytic bone lesions. They've tested multiple myeloma in all kinds of different ways. You got to be ready for that. Hope you found this video helpful. I'll see you in the next one.